One of the most fascinating aspects of PRI for me was the discovery that all the dysfunction that I was having in my lower body, especially the plantar fasciitis that I had for 4.5 years in both feet in my mid-20s, and then the SI joint dysfunction, and then the neck spasms, had many of their origins, most likely, in my teeth and neck. Now, we generally don't think of it like that because we think, well, feet are a feet issue and SI joints are at the pelvis and the lower spine. But you have to recall or realize that from the sacrum, from the base of the spine, all the way up to even the occiput, so the base of the skull, and then all the cervical vertebrae, all the thoracic vertebrae, all the lumbar vertebrae is all one functional unit. That's the important thing to realize. If it's all one functional unit, that means anything that happens at the occiput, anytime the occiput's relationship to the cervical spine is thrown off, so maybe the head is resting like this, or maybe it's resting like this, or maybe it's rotated in one direction or the other, and it's staying in that position, that's its normal resting state, that will throw off the mechanics of the spine all the way down from the neck to the thoracic to the lumbar in rotation and side bending and extension, and that can very easily, very, very easily cause issues at the SI joints. And just to back this up for what I'm saying, it's all in the literature. Go to Pubmed, and I'm just going to read a couple, and I'll attach pictures of the actual studies that I'm reading from, and it's all in the research. It's not even a question. The fact is, people don't read the research. And so let me just read a couple things here. Now let me start by saying, there is a word, and I'm not going to pronounce it perfectly every single time. Stomatognathik. I believe I'm saying that correctly. And when I'm saying stomatognathik, I will be talking, that means teeth and neck. Everything like up here. Teeth and neck and all the associated musculature and bones. Okay, so teeth and neck. Keep thinking teeth and neck. Make no distinction between teeth and neck. Just assume they're natural extensions of each other because muscularly they are. That is the issue. Teeth and neck and jaw, especially, are indistinguishable from each other, and that goes for the whole body in general. It's all one unit. They're not separate. They all affect everything else. So let me just start with this. This is from 2009 from Sao Paulo, Brazil, and the researchers say, these studies suggest that tension in the stomatognathik system can contribute to impaired neural control of posture. If you've watched my videos, you know I always say this is a neuromuscular issue. PRI is neurological. It's not as much muscle. I mean, obviously it is muscle, but it's a neurological issue. Neuro control of posture. That's what we're talking about. These are patterns. These are neurological patterns. These are behavioral patterns. These are neuromuscular function patterns that we get stuck in that put us in certain positions that we can't get out of, and they cause pain. So again, these studies suggest that tension in the stomatognathik system, teeth, neck, can contribute to impaired neural control of posture. Numerous anatomical connections between the stomatognathik system's proprioceptive inputs, teeth, and all sorts of nervous receptors, and nervous structures are implicated in posture: cerebellum, vestibular, and oculomotor nuclei, superior colloculus. If the proprioceptive information of the stomatognathik system is inaccurate, so perhaps you have too much bite on one side, or you have a cross bite and you're making inappropriate contact. If the proprioceptive information of the stomatognathik system is inaccurate, then head control and body position may be affected. Not maybe, it is. I see it nonstop. I'm not a dentist. I can't necessarily help all these people. Well, some people I can, because they don't really have they don't truly have a dental issue. But when their jaw shifts forward or in one direction, quite often to the left, sometimes to the right, but quite often to the left. They'll find their chin is off to the left, so their jaw. It's creating inappropriate proprioceptive contact, too much tooth contact, and then that creates issues in the neck and then all the way down because muscle tension increases and they now have a impaired neural control of posture. So that's number one. Here is a position paper by, I'm not even sure who this person is, but the relationship between the pelvis and the stomatognathic system, a position statement. And this gentleman and I'll take a picture of this and I'll post it. The emerging evidence is indeed finding that relationships exist between ascending, so from the feet up, between ascending and descending contributions to temporomandibular dysfunction and postural dysfunctions. In one study, a correlation was found between foot motion, position of the innominates, which is the pelvis, foot motion. I talk about how many videos have I made about foot motion. Supination, pronation, resupination, heel strike, arch, push off big toe. I talk about it all the time because I can work with it very easily. Teeth I can't really work with, and vision I can't really work with either. Feet, if you understand feet, you can get so many better outcomes for clients and patients. At any rate, because you can figure out where the hell this is coming from. At any rate, in one study, a correlation was, you might realize I'm pretty passionate about this. So in one study, a correlation was found between foot motion, position of the innominants, which is the pelvis, the left and right, and vertical facial dimensions, narrowness, and expansion, but probably narrowness. In another study, it's not uncommon to find a narrower right temporal bone, a narrower right side of the face with a supinated right foot. You see it all the time. Why? Because they're stuck on the right, overactive right SCM starts pulling on the temporal bone and it internally rotates. So it becomes narrow, or it stays narrow. In another study, that an ACL injury may have an effect on muscle activity of the head, neck, and trunk muscles. So old injuries can cause issues up here. And once the tension increases up here, of course, that can then shift the jaw. And now you have aberrant tooth contact. And now you have a tooth issue, which isn't really a tooth issue, but you go to a dentist or a TMJ doctor and they're saying, you got a messed up jaw, not realizing it was coming from an old ACL injury. Apparently, the spine's position can affect occlusion, no crap. And occlusion can affect the neck, spine, and pelvis. Occlusion, how your teeth touch, can affect the neck, spine, and pelvis. So I could go on, but no point. I think you see the point. Let's see. This one says, there was significantly more dysfunction in the patients compared to the control groups. Postural and muscle function abnormalities appeared to be more common in the cervical mandibular disorder group. And I'm not sure how they're measuring craniomandibular disorder. Muscle function abnormalities appeared to be more common in craniomandibular disorders. Cranium, mandible, jaw disorders. They're probably just going by pain or, subjects, how they describe their pain, how it affects their life, probably something like that. So we already know. It's there, another one. And then I think there was another one. Changes in weight distribution at the feet. Changes in weight distribution at the feet due to occlusal supporting zone loss during clenching. The weight distribution was shifted anteriorly during clenching, regardless of the condition of the occlusal supporting zone. So if someone is clenching, you're most likely going to find that their weight has shifted anteriorly at the foot. What does that mean? Pelvis will rotate forward, rib cage will extend, they are in a state of extension. If they're clenching, there is instability somewhere, their weight has shifted forward. If the weight shifts forward anteriorly in the foot, they have to go in extension, otherwise they're going to fall down. Additionally, weight distribution shifted more laterally to the opposite side of the lost occlusal supporting zone. So if I'm clenching on the right and I lose the occlusal supporting zone on the left, they said it kind of weird, but that's basically what it's saying. If the occlusal zone is only on the right side and not the left, the weight shifts towards the right. And what do we find in PRI all the time? Because of this rightward oriented position of the pelvis and the spine and the whole body in general, is 9 times out of 10, maybe more, if you ask someone whether they have more contact on the right side or the left side, especially at the molars, if it's not even, they almost always say the right side. Why? Because again, that right SCM is not turning off, their foot is in a supinated state, they're oriented to the right. All right? And I think that's all I wanted to go over. So the point is, all of this is related. It's all in the literature. You can go on Pubmed, you can do all the research in the world. This is not a PRI idea. As Ron said, he just reads the research. He didn't invent anything. PRI reflects how the human body operates. It's not a system. It is what it is. It describes how humans position and move themselves in space and time in relation to the environment. And that movement involves sensory input. That movement and that stabilization, the ability to stabilize your body upright against gravity, is challenging. You don't realize it because you're using extension muscles, low back, hip flexors, neck, to stabilize your body in compensation when you've lost the ability to move with the appropriate musculature. So that can be covered up for a long, long time because those are really strong muscles, but eventually it catches up to you because you are supporting yourself in extension, in compensatory muscle action, and that can only last so long until it no longer works and you start to end up in pain. So I just wanted to get that out there because a lot of people ask me about that and people are really shocked. They think this is just a PRI idea. It's not. Again, Ron did not invent this. He just read the research. It's stated, I mean, it's obvious. My next video, I'll actually talk about my personal situation, what I had to do, which involved getting an acrylic mouth guard after getting out of my right torsion position and how I integrated or had to use a dental intervention to help restabilize my body after getting out of that right torsion position. If you like this, just please like it, comment. You could subscribe to the channel, or you could send it to somebody else who might have TMJ issues or teeth issues and say, you know, this might be worth watching. I'd very much appreciate that, and because it will help a lot of people. Thanks.